Hello again, guys. My name is Patrick Fay, and this is my final PowerPoint for MN 661. It's about young adults and mental health. I chose the population between the ages of 18 and 25, and I'll tell you more here shortly. Again, with the age group of 18 to about 25 years old, we'll see many different mental health conditions that can affect this age. Specifically, I'm going to talk about bipolar, not so much about major depressive disorder, general anxiety disorder, and drugs and alcohol abuse disorders. There's some other ones that I could kind of relate to PTSD or ADHD, but for the purpose of my PowerPoint, I'm going to discuss mostly bipolar. Um, so, mental health disorders are increasingly common among young adults, according to the uh, National Institute of Mental Health. Young adults 18 to 25 years old have the highest prevalence of any mental illness. That's 36.2% compared to 29.4% for adults aged 26 to 49 and 13.9% for those age 50 and older. That's US data statistics. I created a nice little pie graph for us on this slide here, and overall talked about bipolar disorder over here on the side. The prevalence of bipolar between 15 and 19 is the highest, and then it's higher in females than males, and disorder is the third leading cause of burden of mental health disorders among adolescents and young adults between the ages of 18 and 25, I believe. Um, and then in the pie graph, the little purple pie section there is the other section that basically you have PTSD or ADHD falls into that category, but you see the highest prevalence is related to drugs and alcohol abuse for this age group. And then the second is general anxiety. The third is major depressive disorder. And then last, the smallest amount is that bipolar um, disorder. Um, and treating young adults with the new onset of bipolar disorders requires a tailored approach addressing their unique development and psychological needs. This age group is often faced or often faces significant life transitions such as starting college, entering the workforce, which can also exacerbate these bipolar symptoms. The incidence of bipolar disorder in this age group has been increasing globally. The highest incidence of bipolar is again between 15 and 19, and the disorder is also highly associated with substance abuse, hospitalizations, legal problems, academic and psychological and psychosocial dysfunction, and suicide. Um, Understanding these trends and data can help in developing a target intervention and support systems for young people affected by bipolar disorder. So, discussing unique treatments on this slide, we have medication management, which is ensuring adherence to prescribed medications like mood stabilizers, antipsychotics, and antidepressants. Regular monitoring and adjustments are necessary for managing side effects and optimizing efficacy. And then next, you have psychoeducation, educating your patients and their families about the bipolar disorder, its treatment options and coping strategies can help empower them and manage the condition effectively. And then last, you have supportive services, providing access to vocational training, educational support, and social skills can help these young adults navigate their daily lives and achieve their goals. For this slide is psychotherapy options. Um, You're going to also have cognitive behavioral therapy, which can help patients identify challenges, distorted thoughts and beliefs, replacing them with more realistic um, beliefs and thought patterns. And then it's kind of the reframing process. This can be beneficial to managing mood swings and psychotic symptoms. DBT, which is um, dialectic dialectical dialectical behavioral therapy, sorry, combines cognitive behavioral therapy techniques with mindfulness practices to help patients regulate their emotions, tolerate distress, and improve interpersonal relationships. And then you have family therapy as an option involving the family of these bipolar patients. Um, can improve communication, reduce stress, and provide a support system for the patient. So we see a lot more of this family therapy now with bipolar patients than you did in the past because unfortunately the burden of health care is starting to fall on the families of some of these groups. And then lastly, group therapy. Group therapy offers peer support and helps patients develop social skills and coping strategies in a supportive environment. So they can kind of just do their processing and um, kind of tips and advice to one another and learn from each other's mistakes. I see this uh, works great, and um, the therapy that we provide sometimes, and also at a facility called the Gateway House. If you guys haven't ever heard of that, you might want to check it out. I know they have it in South Carolina, and I think they've spread out throughout other states. So, talking about personal triggers and the fact that uh, with the bipolar patient, I have a sister who I am the primary caregiver, POA, and personal rep for, and that can be stressful just because seeing some of these other patients, I know what they're going through, and it can be also a trigger for me. I have my sister, and then someone in each generation has been genetically predisposed for bipolar and had some kind of trigger that initiated the symptoms. For my sister, um, every time she gets manic, it kind of reminds me of how she was the first time she became manic before she was more controlled, and that happened directly after my mother's passing, which was very trauma and inducing and traumatic for both of us. So I know that I have PTSD from it, but I manage it. And um, some of the other things that could possibly come up are emotional overload, witnessing similar symptoms in patients that evoke strong emotional responses and memories of family experiences for me could be an issue. Empathy fatigue, constantly empathizing with these patients, may lead to emotional exhaustion, and especially if I've had unresolved feelings about my family members' struggles. Um, I have gone to therapy for it and feel like this class has been very helpful too. It just kind of like um, built on the therapy I'd already initiated um, before school, and um, been able to use what I've learned to help instruct others through psychotherapy. But then you have the boundary issues as possible, um, being difficult maintaining professional boundaries due to personal connections with the disorder. Um, Stressing anxiety can cause issues managing patients while dealing with my own personal stress or personal emotions. But I do plan on taking time off and self care and use using what I preach as far as psychotherapy. So I do enjoy everything that we've learned in our course, and every day I've learned more and more. So it's helpful. And then guilt and self blame, feeling guilty or blaming yourself for not being able to help my family members more effectively. Um, and then helping strangers despite that. Um, I don't think that's going to be an issue, but that's just another possibility for a personal trigger. So I only discussed with ethical issues one of the four main principles of medical ethics, but all of them pertain to bipolar schizophrenic patients or all patients in general. Um, they are autonomy and beneficence, non-maleficence, and justice. So autonomy is respect for the patient's right to make informed decisions about their own health care. Beneficence is the obligation to do good and promote the patient's well being. Non maleficence is the duty to avoid causing further harm. And then um, justice is treating all the patients fairly and equitably with equal access to healthcare resources. So, although all those applied, on this slide, I only mention one of those, and then I mentioned some other ethical issues that you might run into. Is informed consent is a issue with this patient population because they might not understand or be able to uh, properly consent due to impairments of severe mental illness. Um, Patient autonomy, balancing respect for the patient's autonomy with the need to provide appropriate care can be a challenging, especially when patient refuse treatment or lack insight into their condition. Um, Dual relationships, navigating dual relationships such as treating a patient who has also been um, a family member, friend, colleague, something like that, can cause ethical dilemmas where you have a conflict of interest, um, such as with my sister. I do try to look out for her and her treatment medication wise, what she's on, but I'm not going to be the provider who actually prescribes those medications or manages those. I just kind of work in conjunction um, with the family side and only observation or recommendations as I learn more about medications. Kind of like she was suffering from morbid obesity, and they had her on um, mitib- mitizerpine. I don't know if I'm pronouncing that correctly, but it was causing her to want to eat more. So I just knew after our last class that that can cause people to have um, a uncontrollable drive to eat. So that's kind of what she was facing. They got her off that medication, and um, she started to get back to a better weight and was doing better and felt better both mentally and physically. Um, but countertransference, managing a psychological phenomenon, which is where I could project my emotions and experience and bias on the patient during care. That's could be an ethical issue, but I just always keep in the back of my mind that you know just because I have family who've gone through it, they're not my family, and they might be going through it in a different form and fashion than we went through it, but it does still help me with empathy and understanding where they're coming from. And I do want to help that population group because it's so underserved and it was so difficult to find help whenever we were going through it. So, overcoming and resolving these previously discussed triggers, I can use reflective skills to encourage self awareness and critical self reflection, allowing me to recognize and manage the triggers effectively by understanding my own emotional responses. Um, I can maintain objectively and provide better care. Um, by having mindfulness uh, that goes along with empathy. I can practice fostering the empathy providing and promoting non-judgmental awareness of my own and others' experiences, um, helping build stronger therapeutic relations, and responding compassionately to the patient. Um, for well-being, um, regular mindfulness practice improves overall psychological well-being, reducing stress and burnout. This allows me to stay resilient and maintain a positive outlook even when I was faced with challenging situations. Um, and then going on talking about resilience more, um, is the ability to tolerate uncertainty and cope with the difficult emotions. Um, and this will help me remain calm and composed, ensuring that I can handle personal triggers without compromising the patient's care, and and sometimes knowing when you need to refer out, or recommend to another provider. You won't be a perfect fit for everybody, but um, knowing when to do that is just as important as knowing how to treat the patient. Wrapping up the PowerPoint with the conclusion, practicing as a psychiatric mental health nurse practitioner will be both stressful and rewarding. At times, all health professionals face inescapable triggers, so will I. The goal is to understand these triggers, implementing self care, and having the knowledge of how to utilize the same resources for myself when undergoing mental health distress. So, back to the if you, um, you know, teach it, then I should, um, like, also do it. So, yeah. I was wanting to say, do as I say and not as I do, but I will do as I say for myself and recommend towards others in this situation.